Fighting the beast from the inside.
No, you probably did.
Oh, okay, yeah. All right, cool. Thank you.
All right, well, see you around.
Okay, so again, everyone has 15 minutes. And there's 3 15-minuters.
Yeah, and I would say just give everybody like 12 minutes to present. Yeah.
Sweet.
That seems fair. Right?
Yeah. So I'll just like show the time for 5 minutes left at the 10-minute mark.
Yeah.
How are you thinking?
Oh no, so your reminders will be for their presentation time.
Okay.
Yeah. Oh shit. Yeah.
Maybe should I ask the presenters about that?
Yeah, so Habib is there.
Okay.
But I feel like limiting the presentation is more important because questions may go a little more.
Yeah.
If such is the case, I can try and think of time. I can try and time the questions. I feel like
Okay.
yeah.
Okay.
Yeah.
Okay, so I can tell you in 1 minute left or 5 minutes left. Okay. Okay. And I'm putting right there with I think it's I'll tell you again. I'm sure you're
Yeah.
Yeah.
All right, everyone. Hi, my name is Kevin Zhu. I'm with the Water Institute at UNC. Welcome to the Dogwood Room for our verbal presentations on COVID-19 surveillance this afternoon. Today, we'll have three speakers. First up, we have Habib Yakubu from the Center for Global Safe WASH, located at Emory University. So please join me in welcoming Habib.
Okay, welcome to the session. Today I'll be talking to you about environmental surveillance for SARS-CoV-2 in the Greater Accra region of Ghana. This is a proof of concept study. And this work was done in conjunction with the Ghana Health Service, CSIR Water Research Institute, the Trend Group, and then the Center for Global Safe WASH. So this work took a lot of effort. The picture you see is just the lab team. In total, we had about 48 people who were directly involved in making this work. So it's very important that before I start, I acknowledge all the support from all the partners who made this work. And also this was supported by the Bill and Melinda Gates Foundation. So in summary, as we all know, most of us know here, there are very few examples of the practical application of environmental surveillance in low resource settings to inform public health action. This study took place in Greater Accra region, where 9.4% of the households are connected to sewer system, and 40% rely on public toilet systems, shared public toilet systems. This study took place from January through May 2021. And out of the 134 samples collected from on-site public toilets, 11.2% of the samples tested positive for SARS-CoV-2 RNA. The samples that were collected from the sewer system, 35.1% of them tested positive for RNA. To our knowledge, this will be the first reported detection of SARS-CoV-2 in fecal sludge from on-site public toilet systems in low resource settings. So what was the objective of this study? It was to develop a strategy for wastewater surveillance in low-income urban settings with a mix of sanitation systems. As we know, in low resource settings, we don't have what we have, especially in high-income countries. So there are a lot of on-site sanitation systems, not sewer systems. So the goal was to do this so that it could be applicable in low resource settings. And what was the rationale? The rationale was to gather information weekly to inform public health decision-making during the COVID-19 epidemic. What's the approach we used? Because this was at the height of the pandemic, although it was a proof of concept study, the information we gathered had to be used to inform what was going on. So it was important we understood what was going on and who are the stakeholders that are involved in this. So it was important that we integrated whatever we are doing in the existing system, the Ghana Health system. There were national and municipal technical committees that were engaged with COVID-19. They had to be part of this work. And the study site, most importantly, was informed by stakeholders. So the hotspots that we looked at was informed by information from stakeholders. Also, because we wanted this information to be used, all the study sites were mapped. In the settings that we worked, there were no maps. All there were sewer systems, there were no maps. So we had to map from the scratch. There were labs, but they didn't have expertise in this type of work. So we had to build capacity of the labs to make sure they're able to do this. And when this was happening, as we know, this was almost all in high-income countries. So how do you do this in a low-income country? You have to adapt the concepts, the methods to fit the local context, and also resources. There was, as we all know, there were supply chain issues. So the lab had to work with what they had. So what was the levels of stakeholder engagement that took place before we started the study? We used a formal stakeholder analysis framework to identify stakeholders. So we identify who the key actors were at the national level, at the regional and municipal level, and also at the community level. And also we plan to have key activities that will integrate with all these existing systems that were on the ground. So before we started this work, we had a national level stakeholder workshop. At this workshop, we talked about what we are planning to do and what will be the challenges if we undertook it. There was a general agreement that this should be done. Based on that, we were able to roll out this study in the study communities. So these are pictures from some of the stakeholder engagements we had. And this is from one of the study sites. This is the Korle-Klote Municipal Assembly. And this is from the Tema Municipal Assembly. So we had extensive stakeholder engagement even before we started work. And this stakeholder engagement was ongoing. So whilst we were collecting samples, the results were coming in, we are engaging with stakeholders, telling them as soon as we get positive results, we let them know. If we have negative results, we let them know. We are looking at clinical samples, clinical results that were coming in from these two communities. So this map, as I said, we developed from scratch because the community that we were working in, although they had a sewer system, there was no map. So we had to map this to understand if we collected a sample from a community, from a manhole, what does it mean? Where is it coming from? How will this inform public health action? The same applied to the community where there were public toilets. What we did was very important because public toilets serve a lot of people. But in these communities, we needed to understand where the people were coming from the community. So we did an observational study. We had to know how many people were coming to that public toilet, how far they were coming from. So the boundary, you see the black boundary, that's how far people were coming from to visit these public toilets. So that when we have information, we know where they are coming from and to use this information to inform action. As I mentioned, these settings are different from what you have in high-income countries where you have auto-samplers everywhere. We had to adapt based on the resources that were available, and these resources, we wanted to be sustainable in the long run. So you could see some of the pictures as some of the implements we used to collect samples, and these were all locally made. You might have heard about more swabs. We tried it. As soon as we put it in a manhole, we went the next day, it wasn't there, it was gone. Why? Because the type of stuff you see that comes through the sewer systems. So we had to improvise. The improvisation was putting on fishing weights on the mole swab. So it could keep it steady so that we still can get the type of information that we want. So these are some of the pictures from the sites. On the left, you see sampling from a public toilet, and the right from a sewer. More pictures of how this was done. It wasn't easy. So you generally have an idea of how a septic system works. But these public toilets, each of them was different in terms of how they were designed. So you had to understand how these public systems works. Some of them, unfortunately, we found out were linked directly to open drains. Which is against the law, but it was happening. So if you didn't understand how the public toilet worked, it will guide you in terms of where you collect your sample and what does the sample mean. During this period, to inform the public health authorities, we developed a dashboard. And this is a dashboard from Community 2, which had a sewer network. In general, what we saw was that the strength of the PCR signal that we found corresponded to the clinical cases. In the public toilets dashboard that we saw in analyzing the results, what we found was that this was a very low income community. So at the bottom, sorry. So if you look at maybe I'll just go there. This point, at that point, there were no cases in that community, but we were able to detect it in the public toilet system. This information was used to guide public health action in that community, because although everybody was lax, when we collected sample from these communities, we showed that something was going on in that community. Based on this information, we gathered stakeholders back again and said, this is what's happening. And then stakeholders in Ghana decided that in order to scale this up, there were critical steps that needed to take place. One, the Ghana Health Service. They were perplexed because there were 6 districts in Ghana that hadn't reported any COVID-19 case at all. They said, if this is useful the way we think it is, can you go and see what's going on there? Also, they were, now that everybody knows how useful this is, people are now thinking about how to use this to detect variants, and how this will be used to mainstream and scale up environmental surveillance across Ghana and also in West Africa. These are some other recommendations, but one of the most important recommendations was that, how can you use this for other pathogens? Ghana has a particular history in terms of their disease mortality, and cholera is one of them. Diarrhea is one of them. Typhoid is one of them. They said, can you use this to detect that? When the COVID happened, all schools were shut down in Ghana. It took a long time for the school to open up. And we saw examples across the world of this being used in schools. So Ghana Health Service was, can we use this in schools to help to guide our public health decision making? Luckily, based on this work, we had support from the Rockefeller Foundation, and we just started implementing some of these suggestions. So as I'm talking to you now, we have some results coming in. We are conducting multi-pathogen environmental surveillance. This includes cholera, Vibrio cholera, typhi, group A rotavirus. And unfortunately, in those districts where they hadn't reported any COVID-19 case, as I speak to you, the results we're getting in for the past 3 weeks, we are now detecting positive cases from almost everywhere you think about in the community. But there hasn't been any case reported at the hospital to date. In addition, there's, because of climate change, there's a lot of rain, flooding going on, and that even some countries, I can say in Nigeria now, there's a cholera outbreak because of flooding. And Ghana and Nigeria are almost the same in terms of how the communities are. And it's likely that cholera will also come up. Based on the results we are getting in now, I'll say about half of the samples that we are getting now are positive for cholera. But nobody has reported this in the hospitals yet. So in summary, I would say this is useful, and we hope that based on the approach we've used, this will be scaled up nationally to inform decision making. Thank you.
Please feel free to use the microphone.
So did you see differences more spot here. And another thing I was wondering about is what your laboratory method for like, if you just look at the solids or if you look at liquids as well. And
Thank you so much for your question. Yes, we looked at MOSWAB. And before we started this work, as I mentioned, we wanted to make sure this is adaptable to the local context. So we had, when we had a MOSWAB, when we had a grab sample, most of the time we had MOSWAB coming out as having more in terms of, sensitivity was more sensitive than the grab samples. In terms of solids and liquids, yes, we treated them differently, and I can give you more information in terms of the methods we used.
Maybe they were probably after, but just curious. What was the target that you already using for cholera? Was it PCR target or was it for PCR? And is there, how big was the kind of complementary clinical surveillance going when you said that the cholera cases have been reported in the health facility? Is there regular surveillance going on in those facilities?
Yes, thank you, David. Yes, so it was PCR. It's a PCR target for cholera. In terms of surveillance, Ghana Health Service prides itself to have a very established, good routine surveillance system. So if you might have heard recently, there was Marburg virus, and it's because of their good system, that's how they were able to pick it up. So this actually baffles them that we are having this and people are not reporting. So there might be other factors that lead to this. Thank you.
Were your stakeholders more interested in the data you provided? Were they more interested in analyzing it in a retrospective fashion or?
Yes, because when we did this, it was during the height of the pandemic. So if you see some of the graphs I showed, the cases were going up. So actually we did at a good time. It was a good time. So they were interested in what's happening now. As soon as we get results from the lab, they want to know what's going on so they can inform how they do. Because they realized that before, because there were issues with hospital beds and stuff like this, this early warning system really assists them to plan ahead of time. So they were more interested in getting information rapidly and you making use of that information.
Thank you.
Right.
All right, thank you, Habib. All right, next up we have Ryan Julian from Michigan State University. Welcome.
Hi, everyone. Today, I'll be presenting my work on building level wastewater-based epidemiology for COVID-19 surveillance on a university campus. Before I get started, I'd like to thank the large team that helped enable this work, the wastewater sample collection team, the Rose Lab Group, MSU's infrastructure planning and facilities, residential housing services groups, and the early detection task force. This work was funded by the Michigan Department of Health and Human Services, as well as Michigan State University. During my presentation today, I'll discuss data collected for this work, a few analyses and the results, and then describe some conclusions. I'm going to try to fit a lot in here, so I'm going to get to it. The basic premise of wastewater-based epidemiology, or WBE, is that some infections can produce biological markers that can be measured in wastewater, and that wastewater surveillance for these markers can inform monitoring about the spread of disease. This information can then be used to limit the spread of disease. The SARS-CoV-2 virus, the causative agent of COVID-19, can be found in the feces of those infected and identified with wastewater using analyses like PCR, making WBE suitable for monitoring COVID-19. We can imagine an oversimplified model of this, where the wastewater concentration is dictated by the per capita shedding rate multiplied by the number of shedders, all divided by the wastewater volume. Things aren't actually this simple, which I'll touch on briefly later. While this simplified model doesn't consider scale, scale does presumably impact results due to factors like smaller populations where each case has a larger impact on the results, and limited transit time, which reduces the impacts of decay and limits hydraulic mixing. Samples for this work were collected twice weekly using automatic composite samplers, and these samples were collected over a period of 7 hours. This time frame was selected to better capture feces. Grab samples were taken when the equipment failed. Sample sites that capture all of the wastewater from a single building were prioritized at the beginning of the study. And then that project, as the project expanded, we also included buildings that aggregated wastewater, included locations that aggregated wastewater from multiple buildings, partial buildings, or some combination thereof. The schedule also changed multiple times throughout the program to avoid buildings where no students were present and to expand the project. So when students moved home for the summer, we didn't sample from those buildings. This is an ongoing project with over 2,000 samples collected to date and analyzed for SARS-CoV-2 via droplet digital PCR. They were also measured, properties were also measured such as pH, temperature, and turbidity. However, this work focuses on the 994 samples that were collected during 2021, as I'll mention in a moment. In addition to the wastewater data, several other data streams helped to support this work. The number of isolations and quarantines were provided with daily resolution, as well as occupancy counts with weekly resolution by residential housing services. Case identification was aided by our university's early detection program, which provided weekly asymptomatic screenings for students. We also collected building level water meter readings to act as a surrogate for wastewater volume to construct 2 different variables, vol daily and vol count, which are the daily water volume used in a building and the amount of water used during the time that the composite samples were collected, respectively. So it's important to understand that we do not have perfect information about cases. It is expected that some cases will go undetected. Further, some students might use bathrooms in other buildings, or infected visitors could use bathrooms in the building that we're monitoring. These can result in both false positives and false negatives. Further, it's important to note that the efficacy of case identification has changed substantially throughout the pandemic, and evidence suggests that cases at present are less likely to be detected than a year ago. To focus on more consistent case identification data, only the 994 samples collected during 2021 were considered for these analyses. As I mentioned, building level case data were collected. And with this information, we can determine the number of people with a new isolation or quarantine, or who were in isolation or quarantine on any given day. However, what we're actually interested in here is the number of people who are shedding virus in their feces. While these constructed metrics are presumably related to the number of fecal shedders, it's important to keep in mind that they are not the same metrics. To help address this, we tried to estimate the viral shedding period. It was assumed that an individual was shedding virus on the day that they tested positive, as the case was identified, and some students were relocated to alternative living spaces after being identified as a positive case. And it's assumed that they contribute to wastewater only in the building that they are assigned to on any given day. This metric considers that movement, making it somewhat agent-based. It was also assumed that infected people shed the virus uniformly for a number of days, and this analysis considers 0 to 21 days prior and 0 to 21 days post case identification. The count of shedders was calculated for each of these 484 combinations, and correlations with wastewater concentration were reviewed to determine the shedding period, which provided the most compelling results. Results show that the largest correlation assumes that individuals shed virus for 8 days prior and 13 days post case identification. This count, identified as num shed, was used as a constructed variable for further analyses. Next, contingency tables were developed for each of those dependent variables described so far in this presentation. It is assumed that at least one infected person must be present in a building for the virus to be to be detected in wastewater, and that virus would not be detectable in wastewater if there were not someone actively shedding virus in the building. For each of the proposed dependent variables, the count of data points were organized into either virus detected or not, and the number of and whether the dependent variable on the day of sample collection was either 0 or not. These data were then used to calculate sensitivity, specificity, positive and negative predictive value, and accuracy for each case count metric. Most of these measures had relatively high sensitivity, but lacking in specificity and in positive predictive value. This is perhaps evidence of cases going unidentified, even during the limited period of data that I'm using here. The constructed variable num_shed showed a balance of sensitivity, specificity, positive and negative predictive values, and had the highest accuracy of any measure. As such, num_shed is taken as the count of infected persons in subsequent analyses. Spearman correlations between the measured variables and wastewater results were also calculated, and all of these were quite weak. Val Daly was the most highly correlated at 0.23. These correlations suggest that increased water use is associated with higher concentrations of virus in wastewater. Mechanistically, this is counterintuitive because more water would just dilute the concentrations of virus that we're seeing. However, water use is also directly linked with occupancy, and elevated viral loads may just simply be the result of more people in the building. Sample temperature was negatively correlated with wastewater results and may have more to do with sample type, either composite or grab, than it has to do with the viral decay of the RNA. All of these relationships were substantially weaker with looking at 2022 data, likely due to poor case identification. Next, we conducted regression modeling in an effort to predict the number of shedders, assumed to be equal to the variable selected on the previous slide. Generalized linear modeling was used for this exercise using the Poisson distribution, and this allows us to restrict the output to whole numbers. This model form also assumes that the variance and mean are equal, which is somewhat of a stretch for this data set. All possible combinations of main effects nested models were ranked using the Bayesian information criterion, or BIC, and compared to eliminate unnecessary variables. Results showed that the top performing model excluded only turbidity. All other variables were considered highly significant. However, this is taken as potential evidence of overfitting. Finally, a stochastic model was prepared to estimate wastewater concentrations given a known number of people shedding virus in the building. Building occupancy was assumed to be 100 people, meaning that each person represents 1% of the population. And then the mass and concentration of each infected person species were simulated based on previous research. Per capita volumetric water use was simulated based on actual water consumption that we measured in the buildings on campus. Results of the simulation show a wide range of plausible wastewater results for each infection scenario, and there is considerable overlap between each of the proportions of those infected. While concentrations of the virus do increase with increasing counts of shedders, these are small incremental changes, making it difficult to distinguish one scenario from another. These overlaps in simulated results continue even as the infected population reaches 100%. The median measured result from campus sampling during 2021 was roughly equivalent to the median expected at 20% of the building population being infected. This proportion of infected residents appears implausibly high, and estimations for fecal mass or viral load may be higher in reality than simulated. Further, water use may be lower in reality, leading to more concentrated samples. Additional study is needed to narrow the uncertainty in these measures. So to bring this back to some conclusions, we estimated the fecal viral shedding period to be 8 days prior and 13 days post case identification, and used this information to construct a new variable. Poisson regression was used to identify factors with the strongest contributions to this new variable, suggesting that the concentration of virus, the daily volumetric building level water consumption, and pH are significant. Finally, the considerable overlap in the results of the simulated scenarios suggests the estimations of numbers of infected people will be highly variable and difficult to estimate. And with that, I'd like to thank you for your time, and I'm happy to answer any questions you might have.
Well, awesome. Great work.
Thank you.
Good. You do that's not trivial. That's what food tells you. But back to your variables, right? pH temperature. Why would you? It seems to me that we need to.
Right. So those variables are not variables that we would necessarily expect to have a large impact on these measures, but they were included there so that we could root out whether they would show up as significant or not. And what this is kind of getting at is just that we don't have enough parameters in this model to accurately estimate these case counts. There are a lot of things that go into this, like sewer geometry, hydraulic mixing of the wastewater, viral decay, and there are a lot of those things that are unmeasurable.
And in your composite sampling, were you did you have much clogging? Did you have much variability in actual sampling? You use ISCO sampling?
Yes.
Yeah. There's a lot more than legal material that goes into a college or
yes. It's been interesting. Yeah, it's definitely been an issue. We have had a few problems with clogging. I think we've had more problems with dropping equipment into the sewer or batteries failing because of just the rough conditions that are in there. It's not a lab environment. But during those, for those instances, we did collect grab samples and we did analyze those as if they were composite samples. But that is a factor that's included in that regression analysis.
I'll let my colleagues go after that. So those grab samples, were they different than the composite?
So we did a proportion analysis on those. And the ones coming from, I didn't mention it in this presentation, but we were collecting some from off campus as well. And in the off-campus samples, we do see a significant difference between grab and composite samples. But the building level ones, we don't see that as much, likely due to the scale and the mixing factors that are there.
Yeah, it could be inside the pipes too. They're shedding off the inside the pipes, so it's not a uniform.
Right. Yeah, thank you.
Great presentation, Knoxville and UNC. I was just curious, so we've done a lot of this work too, and I was just curious, what kind of volumes were you doing for your sampling in terms of like from sampling to an extraction? Because we saw some definite problems with that. And then also, I guess to go along with Keller's question, I didn't know if you saw any difference between flow or a dilution factor, because I'm assuming some of these buildings were quite larger than other buildings.
Right. So to your first question, the automatic composite samplers that we're using, we were collecting 300 milliliter aliquots every 15 minutes. So we ended up with a sample volume that was, the target was around 8.9 liters. In terms of the lab side of, is that what you're asking about?
Oh, yeah, just kind of like, so we did filtering to try to capture virus onto a filter. And so I just didn't know how much sample onto a filter or something.
Right. Unfortunately, I'm not positive about that. I'm a lot more on the field side of the things than the lab, but I do know that there was some, I think it was PEG extraction, and I'd have to dig into that more if you wanted more information there. I apologize. What was the second question?
Did you see like a dilution level impact based on maybe the size of the building and the number of students that were present?
Yeah, so one of the things that we're looking at is some of the dorms have large meal halls in them and some of them don't. And so that was one of the big things that made the wastewater different from one building to another. We're aware of that and we're working on figuring out some means to model that. But as of right now, we didn't have any variables that we were measuring for that to determine concentrations, and we didn't do any of the normalization with like the PMMOB.
Yeah.
Thank you. Thank you.
All right. Now please welcome Alistair from Virginia Tech.
Thank you.
You already have one, right?
That's okay.
Then while you're doing that.
Well, Dr. Julian could not have given me a better introduction. And I think a number of the questions asked are very much relevant to the work I'll be presenting on today as well. So my name is Alistair Cohen from Virginia Tech. And so I'll tell you in a moment about the work we did. But I'm also saving, there are so many people, different departments involved in this work, and I'm going to acknowledge that in more detail afterwards, so you'll have a better sense of who is helping with each component. Oh, I like to walk around, but I'll try to stay tethered. Okay. Let me see. So for those of you that may not be familiar, this is the Virginia Tech main campus in Blacksburg. And just before you think it's just absolutely beautiful and rural, just to give you a sense, this is the campus map, and this is how the picture was taken. So there's a whole town behind it. So this project, just to walk through the methods. So on the wastewater collection side, so this is fall of 2020 and spring of 2021 that I'll be presenting. So we collected samples across 17 manholes across the campus, combination of mostly dormitories, other buildings, and then also at the campus outflow. Initially, we started doing collecting samples Sunday, Monday, Thursday, and we shifted to just a Monday, Thursday for and this is a mix of using composite samplers and grab. And the composites were 24-hour composites, so the 24 hours prior to 7 a.m. on these days. And this is just to give you a sense of it. So that's just, I'll come back to the wastewater samples and the analysis there, but that's the first component. And as I imagine the audience in this room is aware, a lot of universities and a lot of groups have been doing COVID surveillance since the start of the pandemic. And so we wanted to take that a step further from surveillance to wastewater epi. And the challenge there is, of course, a good outcome variable. And then, so here, in this case, we were fortunate, very similar to the presentation from Dr. Julian. So for our case data, we focused on students, and our health center had very good records on when students were diagnosed, which they classified as isolation, or people suspected to be very likely to be exposed and likely to also have contracted COVID, which were assigned to quarantine. And I realize for most of you, this is too small to read. So I'll just share with you, this is on the X, we have the week of the year for the fall and the spring semesters. And this is the number of students, not across the whole university, but just for 5 dormitories, large dormitories, which we ended up focusing our core analysis on. And so this is showing isolation and quarantine counts by week. And of course, we have this at a daily resolution. A lot of what I'm presenting is the fun, it all worked out. We cleaned up the data version, but each of these data sets were messy in their own ways. And this was coming in, we thought of it in terms of like hotel bookings. And that's how our counterparts at the university referred to it also, as them coordinating who's assigned here and what room are they in. And then they switched to this room and when the start date was. So it was quite a bit of work just getting this. We also used from the university's public-facing COVID case data, the dashboard for cases across the university. So university-wide for student cases, both on campus and off campus. Okay, great. So now we have our wastewater samples. We have our outcome variable. And now a key challenge, very much well addressed by Dr. Julian and others, is normalization. And so there are a couple ways you can do this. Ideally, we'd have flow data for all of our samples. This was challenging logistically to get flow meters into a lot of the older sewer systems. Virginia Tech is an older university, I'm sure I'll misremember this on the spot, 1872. Thank you. Okay, pretty close. So infrastructure varying across buildings and facilities. So we also, I appreciated a lot of things. I'm excited to talk to Dr. Julian about, but that was something else we thought about. What about as a proxy variable? If we had smart meters on buildings, we could get the water coming in, and that's how utilities bill for wastewater too. The water coming in is used to bill for the wastewater. But what we ended up doing is talking to facilities, and we were able to get, for a lot of the dormitories, they have key card access. And of those, a subsample are 24/7 key card access only on the entrances. And so we worked with facilities, and so we got swipe card data for each of these buildings. And so for students, for non-students, and then I apologize that this is hard to read. This is week of the year on the X for the fall and the spring. The red is swipe card data for students. The orange is students and others, so a little bit higher than the red. And then the gray line at the top, this is the weekly housing counts. So this is from facilities, the official number of students that are supposed to be in the building. And for each of these data sets, we did a different bit of analysis. We were thinking, oh, it'd be great if we could just use that. But we found there was a bit too much variability, and especially at the beginning and the ends of the semesters in particular. Okay, so another table that for most of you, I realize is too small to see. But so this was more just to give you a sense of the results. So here we have the building codes we used for the dormitories we focused on. Here are building codes for other buildings where you might have multiple buildings with one sampling point, and then this is the campus outflow. So we initially analyzed 673 samples using qPCR. I won't get into the details, but there are a lot of challenges with inhibition and the way that was done. And so we were fortunate to collaborate with HRSD to reanalyze half the samples using digital droplet PCR. And so that's the data that I'm going to focus on for the rest of the presentation, the ddPCR results. Okay, so what did we find? So first, just to look at descriptives. So what are we looking at here? So here in gray, so again, this is similar to before, the fall and the spring semesters. And so here you have, this is cases across the university in gray. At a weekly time point. And then here in yellow, this is the cases based on that data I showed you just now, isolation and quarantine, just for the 5 dormitories that we focused our analysis on. And then here, the blue and the green dots. So these are viral copies per 100 ml for the N and E gene sites. Again, the digital droplet results. And then these are just polynomial smoothers just to look at trends across the semesters. So again, this is just the outflow data, so only about 50 or so samples across the year. But already this is just giving us a sense, like, yes, at the outflow, we are indeed tracking the trends that we're seeing in the case data. So, okay, so here, again, yet another table you can't see very well, apologies. But the main thing I want to show you here is, so here on this first column, so here we have the different buildings, including the outflow, and also including our isolation dorms. So we had a couple dormitories that were dedicated isolation dormitories. These were great for us, not great, but great scientifically in a way, as far as proof of concept for the work that we were doing. And so here we have viral copies per 100 ml. And then here we have viral copies per 100 ml per 100 people, normalized based on the swipe card data. And then finally, we have the same thing, viral copies normalized based on the housing data. So what one would expect is that here in the 2 isolation dorms for both the N and E gene sites, we see that once we normalize per population, we see that the means are higher. And it's really just only for these sites. So that gave us kind of a good proof of concept. The world is functioning the way we'd expect, that we'd see a much stronger signal from the dormitories where we have all the cases, or all the diagnosed cases, as it were. Okay, so then the core of the paper. So the core of the paper is, so this is, so we pre-specified our analyses. So basically just before we actually started doing the data analysis, we wrote up an analysis plan, and it's on Open Science Framework if anyone's interested. And at the time, we did our best to think what would make sense, what should we pre-specify as the lead time for what we would expect to see? How far in advance would this be predictive? And we settled on 8 days. So again, thank you, Dr. Julian and colleagues. Now this has changed a bit. And I should also mention a lot of work I'm not discussing was discussions on how can we figure out the shedding dynamics and fine tune this. And ultimately we decided that was just too messy and we needed a more straightforward approach. So we pre-specified looking at an 8-day lead plus or minus 2 days. And so here, so we used random effects Poisson regression. So not Bayesian frequentist, but we're getting to a very similar place, I think. And with cluster robust standard errors. So essentially that means just we're treating the buildings as clusters. So we're not treating each student in a building as independent. The idea being that they're going to be more similar to students that they live with than with students that they don't live with. And our outcome variable, again, is cases at eight days. So just to call out a few things. So here, when we treat our outcome just as a binary, do we detect SARS-CoV-2 or not? So we find that detection was associated with, for the NNE genes, an 85 and 99% increase in the likelihood that we would have a case 8 days later. So, and highly significant results as well. So using now the normalized viral copies, so viral copies per 100 ml per people. So we found that a 1 log increase in the viral copies was also associated with statistically significant increases in the likelihood that we would see cases 8 days later. So there were a lot of things from Dr. Julian's talk that I'm looking forward to discussing further. But one thing I like was the mention of being cautious not to overfit the models. And so similarly, we could have pre-specified, we'll look at every possible day out from 1 to 30 and every other variation, but that was part of why we wanted to pre-specify the analysis. Because if we ran 20 models, there's a chance we might have found something just by chance. So this was our primary pre-specified analysis. But we also looked, and this is in our paper, which is published, we also looked at 4 and 5 days out, and we also saw significant predictive effects at 5 days. So just to wrap up, so what I'm showing you here, so now we're looking at this, again, as before, the X is the same. So this is just the 5 dormitories, just those cases, the ddPCR results. And now here, though, on the Z, we have viral copies per 100 ml per 100 people. And then here we have the COVID-19 cases with an 8-day lead. So essentially, if you imagine, all we've done is we've shifted our case data and the wastewater results. So it looks as if we could somehow magically know the day we sample what cases are going to look like 8 days later. So that's the overlay we're looking at there. So with that, a lot of people I'd like to thank. So this project was really led initially by colleagues in civil and environmental engineering, where I also have an appointment. And in particular, an amazing grad student who's just about to finish up, Ayala, soon to be Dr. Mayele Moskowitz, who really did the heavy lifting, and an excellent PhD student of mine, Amanda Darling, also helped with some of the analysis, and Drs. Amy Pruden and Vixland. Also, other colleagues, Alessandro Sisi, Carla Finkelstein, who did they did all the COVID testing for the university, including the first round using qPCR. I was very fortunate to have help from a statistics PhD student who was kind enough to help with writing the scripts to organize the data, and then also replicated my analysis. And also Dr. Fricker in statistics and Dr. Hungerford in population health sciences. And a big thanks to Raul Gonzalez at HRSD for reanalyzing half of our samples and then helping us look through and interpret the ddPCR results. So with that, I'd be delighted to take any questions. And this is published if you're interested in ES&T has a new offshoot journal, Water, and they have a special issue on this. And sorry, just as an aside, a question that was asked the last time, the difference between grab and composite, we also looked at that because we were curious. So we added that as a covariate in our models to control for that. And it made a difference, but not much. The effect sizes, direction, and significance were all about the same. Yeah.
David Brendes from CEC. I have a question for Dr. Julian as well, but just curious, I appreciate you trying to get to number of cases. Do you feel like you have the data potentially to go one step back to a limit of detection, a positive detection means that there are at least this many people who might have SARS-CoV-2? I appreciate we're jumping all the way to prevalence, but there could be some public health utility in what that LOD translates to in terms of real people, even if there's uncertainty around it. So do you feel like you have data to do that? Any thoughts on maybe how you go about that?
Yeah, thank you. That's a great question. Part of the impetus for this work, I imagine at many universities, was to help the administration. I was, part of a group, as I imagine you were as well, that, provided guidance to the university on their COVID response and management. And so that was the hope with building this out. So I think we showed that it can be predictive with a high degree of confidence, but I think because of all of the messiness with understanding shedding dynamics, we were hesitant to kind of go much past this. But that might just be because, we're academics and maybe somebody on the policy side, would have ways to think about how that could be done responsibly.
Great work. I mean, it's interesting how we all accelerate on this because the needs usually from leadership or something like that wants an answer. To the numbers, right? And you were trying to figure out specific numbers, and I know there's internal standards and the subtleties in a 10-minute talk, but one of the issues there is I think we have to all realize, especially as we go to scale, that this is an art, not necessarily a science in certain aspects of that in real time when you're trying to monitor in there. And as you evolved over time, did the ability to realize that some samples have more complexity and have internal controls that would allow for that adjustment would then drive your numbers if it's beyond a presence absence is something I think we should consider. Student dorms are one thing, but a cafeteria with lipids in there is a whole nother game that makes it challenging for that matrix in there. And so I'd like to get your thoughts as everybody wants this to go forward in a rapid, tricorder way. You think we're there?
Yeah, no, thank you for asking. I think probably not. So I'm an environmental epidemiologist, so I have microbiome training, but my comfort zone is more of the study design and biostatistics. And so a lot of that question would be left to my colleagues in environmental engineering to answer. But I know that was a huge challenge. It was just trying to figure out inhibition and all the different inhibitors, and the wastewater mixes also look different. Depending when and which buildings and if it was grab or composite. So again, that's not my area of expertise, but I think from my viewpoint, I'd say, no, not there yet. It still seems pretty messy. I think, was there a second part of the question? There. All right, thank you.
So that's all the time we have for presentations today, but thank you to our presenters. And yeah, thank you all for attending. Yeah.